Good afternoon, everyone. Thank you so much for joining our clinical ethics sessions called Unpacking Bedside Bioethics. My name is Jamie Connerman-Cease, and I'm an assistant professor of clinical ethics here at the Center for Bioethics at the University of Minnesota. The Unpacking Bedside Bioethics is our quarterly lecture series that focuses on bioethics topics that impact clinical work. And today's session comes from our faculty member at the center, Joel Wu, who will be presenting when clinicians can refuse AMA discharge requests. We're really looking forward to this session from Joel. So let's move on to our slides. So before we get into our session, I do want to let everyone know that the ethics consultation service is available from our center for mHealth Fairview staff members and faculty and patients. So if you work for mHealth Fairview, the Center for Bioethics at the University of Minnesota provides a 24/7 ethics consultation service, and you can contact us via a request in Epic or with our pager listed on this slide. So we have a couple of housekeeping notes for our session today. If you have questions, use the Q&A function to ask or follow up on a question. Let center staff know through the Q&A if you're having technical difficulties. And we will have a time reserved at the end for those Q&A questions so that Joel Wu can answer any questions that come up during the webinar. This session is recorded. It will be accessible at the Center for Bioethics website. A link will be sent out after this session with a link to the recording of the session. So this session will be recorded. We also really appreciate your feedback, and your feedback really helps us inform us how to structure and what topics we should use for these sessions. So please consider filling out the evaluation for this session. It will come in a post-event email and will be linked in the presentation details document. That document was just put in the chat. That document has a lot of information, everything you need to know about this session, and further things just about the session, the Unpacking Bedside Bioethics series in general. We have opportunities for University of Minnesota students, health professional students who are seeking credit, continuing education or continuing credit. We also have opportunities for those of you who are seeking continuing education units. So if you are seeking a CEU, please follow the form linked in the presentation details document, and you can request a certificate of attendance there. If you're a U of M student seeking IPE credit, you are welcome to do so. We have a 15-minute post-event discussion on interprofessionalism, and you're required to fill out a reflection form. You can get both of those, access to both of those, both the link to our post-event discussion and the reflection form in the presentation details document. So please follow that. Our post-event discussion happens right after this event. So make sure you follow the link in the presentation details document for that. All right, I'd like to introduce our speaker today. Today we have Professor Joel Wu, who is joining us as a clinical ethics assistant professor from the Center for Bioethics at the University of Minnesota. Professor Wu also holds a senior lectureship in the School of Public Health. He is co-chair of the UMMC Ethics Committee and is also co-lead of our ethics consultation service. We are thrilled that he is here to present on this topic. This is one of his great strengths on our team when we do ethics consultation. So if you'd like more information about Professor Wu, please check out the presentation details document. And with that, I'll hand it over to Joel Wu to start our presentation today.
Thanks, Jamie. I just want to get this out of the way. I don't have any relevant business or significant financial interest to disclose here. Thanks for joining me, everyone. Let's just jump in. So today we're talking about the AMA problem, the Against Medical Advice Discharge problem. I want to start by briefly describing the problem and then putting some cases for you to think about in your mind as we go through the rest of this talk. So what are we talking about with the AMA problem? This is a situation when a patient requests discharge from an acute care setting against medical advice. And this is going to be with risks for severe and avoidable harms. I think some important distinctions to emphasize here is that this really should be a patient who has been admitted to an acute care setting and for whom there has already been an informed medical recommendation. I want to carve this out from a situation where there is a patient who is leaving without being seen or without medical advice. So this is a situation where there is medical advice that has been provided. I also really want to emphasize that we're talking about a situation where there are risks for severe harms. In a situation like this, there are really two options. And your options here are either an involuntary hospitalization or a discharge, understanding that the patient is at risk for avoidable and serious risks for harm and injury. I want to give you 4 cases that we've worked with here at the university to have in your mind, and then we'll revisit them later at the end. The first patient is a young male with unresolved endocarditis, who has already had a heart valve replacement, and this is on the background of a history of IV drug use and housing insecurity. So he was admitted because of complications of his endocarditis, but he wants to leave the hospital before finishing his course of IV antibiotics. The next patient is a patient with end-stage lung cancer. He was admitted because of respiratory distress and respiratory failure, but now that he's been stabilized, he wants to go home to rural Minnesota to die. Okay. The next patient is a woman in her 40s who has a severe and enduring case of anorexia. She was admitted directly from an inpatient eating disorder program. She's been stabilized, but now she wants to leave, even though there hasn't been clear resolution of the underlying eating disorder. And she wants to go back to a state that her family resides in. She had come to Minnesota for the inpatient eating disorder program. So she wants to leave against medical advice as well. Finally, we have a patient who had an aortic dissection and the placement of a mechanical valve in her heart. The repair was done a little bit over 2 weeks prior to her request to leave AMA, and she wants to leave because she wants to get back to her home where she has primary custody of her children. And right now, her children are with her ex, who normally only has the kids 1 or 2 days every 2 weeks. Okay, so think about these cases. What are your initial impressions? Should we discharge these patients against medical advice, or should we involuntarily hospitalize them? I'd like to get your impressions initially, and then we'll revisit this at the end and see if there's any change. We'll give it another minute or two, and then we'll move on. This is interesting. It looks like right now the vast majority of folks would discharge the patient with the end-stage lung cancer. It's about a coin toss for the patient who is recovering from the heart repair, and it's much lower for the patient with a history of IV drug use and endocarditis, and then also the patient with the eating disorder. I mean, initially I will say I think this is actually very, very appropriate and informed, right? Because especially with the patient with a history of chemical dependency and the patient with an eating disorder, you already have questions about their ability to make good judgment, right? You have questions about their capacity. Okay, so moving on. The objectives for this talk broadly are to explain when an AMA discharge may be ethically appropriate, when, in contrast, involuntary hospitalization, which is a really serious kind of intrusion on individual liberties, may be ethically defensible. And then finally, to describe some ethical and procedural considerations for either one or the other, because you want to do this in an ethical and fair way. Broadly, I would say that the overarching goal here is to provide some guidance on how to improve consistency, certainty, and fairness when patients want to leave against medical advice. I want to give you the takeaways up front, so you have an idea where I'm going, and hopefully by the end of the talk, I can substantiate what these takeaways are. We'll revisit these takeaways as conclusions at the end with a little bit more detail. So the takeaways. Low risks don't justify involuntary holds. You can only really, I think, ethically defend an involuntary hold for severe high risks. Second, people with decision-making capacity should not be involuntarily held. And the process for an AMA discharge should be fully informed and documented. I'll explain a little bit further later, but the elements of the kind of information that you would want to give to a patient for an AMA discharge isn't that different than how you would think about the kind of information that you'd want to give to a patient in an informed consent process. Next, people with impaired decision-making capacity may need to be protected from avoidable harms, but it needs to be with as little coercion as possible. So this is both in terms of the kinds of coercion and also the duration of the hold. And then finally, one of the circumstantial details that is increasingly important, I think, is that the reasons for a hold will matter because of local laws. Most states only have laws authorizing psychiatric holds. Minnesota is one of the states that has a statute that indicates 3 reasons for a hold. It's going to be mental illness, developmental disability, or chemical dependency. Reasons for the holds should be truthful. So if a patient doesn't have a psychiatric basis, it's ethically and practically problematic to try to manufacture a reason to fit a statute when it doesn't exist. And we'll talk about this in a little bit more detail. Quickly, the overview of how I'm hoping to proceed is to cover some background first. I want to describe the definition or the lack thereof, and then also some of the association and effects of AMA discharges to the extent that there's been some research done on it. Next, I want to describe some myths about AMA discharges to dispel, I think, some underlying assumptions that I think are incorrect and problematic. Next, I want to specifically describe what the ethical conflict is here, because this is an ethics talk. And then finally provide some guidance for how to respond to AMA discharge requests. Then we'll revisit our cases. So first, some of the background. I think it's important to address the context and the background here. It's not just to provide information, but eventually I want to show that this is a problem that is morally challenging, and it is a value-laden issue that arises within a societal context, right? And the societal context may create conditions that lead to ethically problematic outcomes. First, about what a discharge against medical advice means. This is from David Alfondre at the VA, who I think is probably the preeminent sort of scholar on AMA discharges. He's written in a number of pieces that there is no clear regulatory or clinical consensus about what constitutes a discharge against medical advice. Furthermore, he says that there is no clear medical legal rationale. Some of the potential value identified is in a procedure for the documentation and the designation when a patient wants to leave against medical advice, because it allows for reinforcing the seriousness of the decision and ensuring that important information is effectively transmitted to a patient. It also creates a record, but as we'll see shortly, it may not actually benefit either patients or clinicians and institutions. It's also important to emphasize here that there's a lot of inconsistency. Not all suboptimal discharges are designated AMA. Which ones are designated AMA and are not are relatively inconsistent because of the lack of standards. And as such, I think the discharges that actually are selected to be designated as an AMA in the patient's record can be a function of biases, right? So why would we tend to more frequently designate a patient who has a chemical dependency issue as an AMA discharge as opposed to not? And the range of these circumstances can be from a patient who elopes to a polite refusal. This is on the background of some really concerning associations and effects as well. What we know of the research is that 1 to 2% of discharges in the US are designated AMA. And this has been a relatively durable finding for, I think, a couple of decades now. AMA discharges are also associated with a higher risk for 30-day readmission and mortality. There are a number of other adverse outcomes, as you'll see. And I think it's important to emphasize here, this is related to the concern for bias, that AMA discharges are associated with factors like homelessness, mental illness, substance abuse disorders, race, low socioeconomic status. Oh, that's a repeat. HIV infection, asthma, cirrhosis, and among other things. The important here is that the AMA discharges, the effect and the distribution of AMA discharges is not occurring in a vacuum, right? And as you can see, these factors are going to aggregate around people and populations that I think are historically disenfranchised. So this is, I think, an ethically concerning issue. Furthermore, there's increasing evidence that AMA discharges are stigmatizing of patients who have the designation in their record, and that for the patients who have the experience of having gone through the conflict of wanting to leave against medical advice and then being designated as an AMA discharge, the narrative evidence suggests that this results in a loss of patient trust and a willingness to follow up for medical care, and also is more likely to result in future AMA discharges. I also want to make a specific aside on reimbursement and insurance here. There's sometimes the belief, or there's sometimes the assertion that an AMA discharge will result in patients' medical bills not being reimbursed by insurance. This is incorrect. However, it's also worth noting that AMA discharges may actually have effect on organizational and institutional reimbursement from CMS. So CMS has programs that tries to reduce the rates of unplanned readmission. And if a discharge is designated as AMA, it actually excludes it from the calculation of unplanned readmissions. So there may actually be some organizational incentive to document or designate more discharges as AMA, because it would make it look like they have fewer unplanned readmissions, and then it would increase the kinds of reimbursements or rewards in a CMS program. But this is, there's no clear evidence of this. I want to emphasize. Okay, and now I want to talk about some myths before we move on to the ethical analysis of the issue. So I'd like to start with a poll on these three statements. These are all true or false statements. The first one is, when a patient declines a recommendation to remain hospitalized, a physician must discharge them AMA, true or false. Second, use of an AMA discharge or AMA discharge forms is beneficial to patients and physicians, true or false. And then physicians are not obligated to provide other treatments and services at discharge when a patient leaves AMA, true or false. for what it's worth, even doing the background research, even having some prior background in this, it's still surprising to see how clear some of the arguments are for or against these ideas. Okay, so a majority of people think statement 1 is false. Majority of people think statement 2 is true, and a majority of people think statement 3 is false. So these are all false, and it's pretty well characterized in, again, some work by David Alfondre. He did a really, I think, crisp and convincing piece in the Annals of Internal Medicine here in 2022. So regarding the first myth, after fulfilling duties to inform and provide an opportunity for a patient to make a choice about whether or not to remain hospitalized or not, there is no specific obligation to do an AMA discharge with the associated documentation and designation. So this is part of the problem of the lack of standardization and consensus clinically and legally. Regarding the second statement, so this is a little bit more difficult because we're talking about both benefit to patients and physicians and also to some extent the organization. So it could be split into a couple of different questions, but the evidence is that this doesn't actually help anybody. Other than a procedure to memorialize and transmit the gravity of a choice to a patient, this probably results in harm to the patient in that it results in a loss of trust. There's a degree of coercion that's involved, and it results in, for example, a reduced willingness to return. For physicians and for organizations, there's actually no evidence that this either improves the informed consent, or in this case, really an informed revocation of consent to treatment process. And most importantly, there's no evidence that this provides any better liability protection. The real liability is going to be about negligence and violations of standards of care, but that's not unique to the situation. There's also risks for faulty consent, and also there are risks for inappropriately holding or confining patients. I think it's interesting because one judge in a case actually said that AMA forms are against public policy and a legal nullity. He's saying that essentially hospitals and physicians can't absolve themselves of negligence regardless of whether or not patients sign the document. And finally, well, the third idea is whether or not an AMA discharge absolves physicians of other duties or actions at discharge. And this is also untrue because I think there is still an ethical and also to some extent a legal duty of care to helping patients as much as you can, even if they want to leave. And we'll talk about this in a little bit more detail shortly. So let's talk about the ethics question. I think it's worth talking about and framing the central ethics question from a principalist perspective. I don't always like doing that because I think it's limited, but in this case, I think it's really helpful because the 4 principles really illustrate a particular conflict. Other frames like virtue ethics and narrative ethics, I think are really, really valuable, practically speaking, but I think they would also rely on a principalist framing to describe or specify the conflict. And here, I think I would describe the ethical conflict or dilemma as tension between respect for autonomy and beneficence, where one expression of beneficence, as argued by Bishop and Childress in Principles, is that beneficence also includes an obligation to prevent harm. The other tension opposing essentially the obligation to prevent harm or to act according to beneficence is respect for autonomy. And so individuals have interest in self-governance, and that means that there's a correlated obligation or a duty on us not to interfere. And so in a situation like an AMA discharge, where patients want to leave despite risks to themselves, which principle should have priority? I think this is really the crux of the ethical conflict. So there's a couple of ethically problematic outcomes. These are the things that we want to avoid, right? And these would be the things that are ethically problematic. The first is inappropriately paternalistic involuntary hospitalizations. So this is when we intrude on our patients' liberties inappropriately and inappropriately paternalistically. The other ethically problematic outcome here is the inappropriate discharge of a patient who does not have effective decision-making capacity, and it results in avoidable harms to the patient that are also inconsistent with the patient's own goals, values, and interests. So we want to simultaneously avoid violations of autonomy and self-governance, but we also want to prevent avoidable harms to vulnerable people. The positive way of framing this issue, I would say, is that we would also want to pursue good outcomes. It's not just about avoiding the bad. And we're talking about the affirmation of autonomy. I think particularly at the end of life, I like to use a narrative framing, which is to say that we would want to honor the autonomy interests of people who have intact capacity. And from the narrative lens, it's essentially to allow people to write their stories on their terms. So, for example, at the end of life, we would want to allow a dying patient to write the story of the end of their life on their terms, and that burdening that or precluding them having the opportunity to write and narrate the conditions of the end of their life is actually really, really ethically problematic. Simultaneously, in the positive, we want to protect the vulnerable from harms. I think a good example that I'll talk about again later is vulnerable people exist in a lot of different circumstances, but for example, with minor patients, it would be really ethically incomprehensible to allow a young child who doesn't understand the risks and burdens as opposed to the benefits of hospitalization to leave and resulting in avoidable harms. So how do we balance and try to avoid both of the bad outcomes and try to achieve the good outcomes, right? What I'd like to do is I'd like to go through what I think are 4 relevant ethical considerations for discharges against medical advice. The first is to think about the severity of the harm to be avoided. The second is understanding the importance and how to evaluate decision-making capacity. So decision-making capacity is really central here. I'm going to talk a little bit about what it means for the specific issue, but I'll also refer back to Jamie's prior talk about decision-making capacity because I think it's really good. Third, I want to talk about the notion of complicity, harm reduction, and even potentially the idea of abandonment, which is to address the idea that if a patient is leaving against medical advice, this doesn't absolve clinicians and the care team from continuing to provide supports and services that are relevant. And the last is I want to talk about some procedural issues and procedural fairness. Okay. First, about harm. The harms need to be, the harms of the potential injuries need to be weighed against the harms of involuntary hospitalization. It's a really serious intrusion on autonomy to involuntarily confine someone to a hospital setting. The effects of this could be, not just the hospitalization in and of itself. It could result in a patient losing a job, losing custody of a child. There are opportunity costs that are really, really important. So the harms, the medical harms, the risk for injuries have to be very significant. It's ethically problematic to defend involuntary hospitalization for minor risks and harms. So it's to say that low levels of risk can only justify low levels of influence and coercion. And if it's a low level of risk, I don't think you can ethically defend involuntary hospitalization. We'll talk about this a little bit more in context coming up. Okay, now for the discussion about decision-making capacity. This is really sort of where the rubber meets the road in being able to make a determination about whether or not a discharge against medical advice is ethically appropriate. First, it's important to emphasize that patients with effective and appropriate decision-making capacity have a right to refuse treatment and also to leave. A number of authors have described a discharge against medical advice as essentially a revocation of an informed consent to be treated. And I think that's correct. So to the extent a patient has the capacity to effectively provide informed consent to treatment, they would also have the capacity to revoke their consent to be treated and also to be hospitalized. So this is really important, right? Because we don't involuntarily treat patients. We require informed consent to the extent patients have decision-making capacity. Similarly, we shouldn't involuntarily hospitalize patients if they have the same kind of effective capacity. And I put in parentheses that this has to be issue specific because there are circumstances wherein a patient may be able to make some decisions, but some underlying psychiatric condition, for example, may impair a narrow area of decision-making. And so, like as we spoke about in an earlier case, it may be that you have a patient with an eating disorder who has impairments in their ability to make decisions about, for example, hydration and nutrition, but they can make decisions about something else. Okay. It's important to emphasize here also that the degree of decision-making capacity needed here, it will scale to the complexity of the decision, and also the degree of information needed to ensure an autonomous and unconstrained decision is also very, very important. But this is not any different than informed consent, right? Because you need to provide effective and informed, you need to provide effective information for a patient to be able to make an informed decision. And you also need to make sure that they have the degree that meet a threshold of requisite decision-making capacity to be able to have valid informed consent. A little bit more about the relationship between decision-making and autonomy to sort of frame the tension with beneficence and when we might be able to involuntarily hospitalize someone and refuse an AMA discharge. So we're talking about decision-making capacity so much, and specifically because decision-making capacity is required for autonomy. In a number of places, I think a really helpful construction of autonomy is that it requires both a characteristic of the individual and also circumstances. And so for there to be effective autonomy, there both needs to be first decision-making capacity and second liberty. And liberty meaning not just freedom from threats or coercion, but also the presence of the kinds of information that would be needed to make an informed choice. So for autonomy, there needs to be both decision-making capacity and liberty. People who lack decision-making capacity are vulnerable. People who are unable to weigh the risks and benefits of either treatment or non-treatment, or hospitalization and leaving, and are unable to align those risks and burdens with their underlying goals and values, are vulnerable. And in those cases, paternalism may be justifiable to prevent the harms to those patients. So, for example, I would say in minor patients, involuntary hospitalization is probably defensible to avoid serious harms. And from the ethics standpoint, what we would say in these cases is that the loss or the relative decrease in the weight of the autonomy interests means that the significance of the beneficence obligations increase. I actually have a quote here from Principles, because I think Bishop and Childress do a really nice job of explaining it. And they say, as a person's interests in autonomy increase and the benefits for that person decrease, the justification of paternalistic action becomes less cogent. Conversely, as the benefits for a person increase and that person's interests in autonomy decrease, the justification of paternalistic action becomes more plausible, right? So preventing minor harms or providing minor benefits while deeply disrespecting autonomy lacks plausible justification. But actions that prevent major harms or provide major benefits while only trivially disrespecting autonomy has a highly plausible paternalistic rationale. So in this case, when we're talking about preventing major harms, you need to have a real good reason to disrespect the patient's autonomy. And this isn't a trivial disrespecting of a patient's autonomy, right? A complicating factor here is the legal and regulatory environment. Due to statutory construction, the basis of a loss of decision-making capacity matters for when you can hold a patient involuntarily under the law. Most states have laws that allow for psychiatric holds. However, at the same time, most states do not have laws that allow for holds on the basis of decision-making, on the basis of a lack of decision-making capacity only. So this poses a problem. When you have a patient that wants to leave AMA, you can either discharge them AMA, but if you're going to hold them, the statutory and regulatory environment sort of requires you, if you want to do something within a statutory basis, to find a psychiatric basis. So for example, in Minnesota, the law requires a finding of mental illness, developmental disability, or chemical dependency, and a risk of causing injury to self or others. So if you want to hold the patient under the law, theoretically, you would have to have a finding of this. The alternative is detainment without regard to specific statutory authority or a statutory basis. And so this is both legally concerning, but I think it's also an ethical problem. It's an ethical and practical problem. The ethical problem is that I think it's unethical to manufacture a psychiatric basis to otherwise inappropriately justify a hold or involuntary hospitalization. The problems are that, first, the presence of a mental disorder does not imply the lack of capacity. The lack of capacity needs to be assessed in and of itself. It's also potentially legally problematic to use a psychiatric hold for someone that doesn't have a psychiatric issue. And then finally, part of the reason why these statutes and regulatory frameworks exist is because the involuntary psychiatric hold also implies a need for psychiatric treatment, which would not be the case if a patient doesn't have a psychiatric issue. Where this puts us is that in the absence of a psychiatric basis, I would suggest that the lack of capacity may be ethically sufficient to justify an involuntary hold or an involuntary hospitalization, but might not be legally sufficient. It's a gray area. And a proposed solution is the idea of a medical incapacity hold as an institutional policy. So I want to emphasize this is a proposal, and they call it the medical incapacity hold because it's as opposed to or in contrast to an involuntary psychiatric hold. So they're the holds where there isn't a psychiatric diagnosis or basis, but there's still a lack of capacity that's going to result in severe harms. There's been some research done, but the only place that's implemented this that I'm aware of is UCLA. So this is not in common practice. I will say that I'm convinced that this is an important organizational, institutional problem, and that I think this would be an effective and ethical solution. So more about these incapacity holds. A medical incapacity hold is going to arise when a patient is making efforts to leave a setting that places them at grave risk for harm. They do not have capacity, and the patient does not meet the legal criteria for an involuntary psychiatric hold. In this case, if the patient meets all three criteria, then the patient shall, according to the policy, be kept from leaving the medical center by order of a treating physician. I think this is a helpful flowchart. This is from the paper that proposes the idea of the medical incapacity hold. So I think the important takeaways here are that rather than only having the two options of either an involuntary psychiatric hold as opposed to an AMA discharge, there is this medical incapacity hold where a patient can be held when they lack decision-making capacity, but in the absence of a psychiatric basis to prevent serious harms. It also requires that there is regular reassessment of the condition and capacity of the patient so that the least restrictive and the shortest duration conditions for holding the patient exists. One thing that I want to emphasize here about assessments of capacity, because it's a really, really central part of the process. A choice that results in injury or death is not per se indicative of either a loss of capacity or a psychiatric or a mental disorder. And so this is, I think, something that resonates with people when I talked about the patient with end-stage lung cancer, right? A wish to die at home outside of a hospital setting is not indicative of a psychiatric or a mental disorder. I recall patients, a Hindu patient from India who had hoped to die in Varanasi because of faith commitments and beliefs. And even though they may not be the kinds of faith commitments or beliefs that we hold, they're not indicative of a loss of capacity. It would be very ethically problematic to assign a psychiatric diagnosis to authorize a hold on the basis of different values or priorities. And so these values or priorities may be anything from faith commitments to concerns about childcare, which is a recurring theme in some of the literature. Okay. About harm reduction and complicity. This is about the third myth that Dr. Alfondre talks about. An AMA discharge does not absolve other obligations to prevent avoidable harms. I think the reasoning and the ethics of harm reduction have been pretty well established. So the classic examples are clean needles for IV drug users. We're not actually contributing to the harm. We're actually preventing harm by giving IV drug users clean needles. I would suggest that withholding harm reduction and withholding other supports, even in the course of an AMA discharge, is problematic because it's not that it's a form of complicity. I would actually argue that it's a kind of a form of abandonment. So thinking about the circumstances of an AMA discharge, when patients are leaving against medical advice, their hospitalization is only one aspect of their medical care. So if we're talking about, for example, a dying patient, if you think that it absolves you of any further obligation, sending a dying patient home without other supports or without other palliative measures, I think would be really ethically problematic. That wouldn't be a kind of complicity in hastening the patient's death, so to speak. It would actually be meeting, I think, the continuing obligations to support the patient, even if they're leaving against the advice of a physician about hospitalization. What I would suggest is that in most cases, withholding assistance and not providing harm reduction during the course of an AMA discharge is actually a kind of abandonment. And I think the most extreme cases are the ones that occur at the end of life. Finally, some thoughts about procedure. It's important here to do things procedurally, consistently, and fairly. So previously, we talked about the idea that an AMA discharge is essentially a revocation of informed consent to treatment. And I think that's a good framework and a good model, because we all understand that when we're trying to get consent, we need to provide all the relevant information. Patients need to be fully informed. I would suggest that that's the same thing here. The obligations to document are the same, and the kinds of information that need to be transmitted are very similar, with a few extras I would propose. So if a patient wants to leave against medical advice, regardless of whether or not you actually designate it in a record, is that you need to document their capacity, an assessment of capacity. You need to provide full information to allow them to have an informed decision. And you also need to ensure that you document that they don't meet other criteria for involuntary hospitalization. I want to emphasize some of the elements of fully informed, in addition to risks and benefits. And these are the last three bullets. I think it's really important for patients who are considering leaving against medical advice to not only know the risks and benefits, they also need to know that they have open opportunities to return. Sometimes patients feel like they can't come back, and that's not true. They also need to know, and following our prior point, that there are harm reduction options and that there are opportunities for follow-up that should remain. So even though they're leaving AMA, we can still provide them with other services and other supports after they've been discharged. And finally, I think it's important to also emphasize to patients here that there's not going to be any other kinds of retaliation. I want to make a couple of legal notes, but you, of course, have to talk to your lawyers. This is something that comes up, so this might be a reaction to some of our circumstances, but hospitalization does not mean that involuntary treatment is also authorized. Even under commitment, informed consent is required for treatment, and involuntary treatment can only be authorized with a court order. I've gone a little long, so I have cases, but we can also do Q&A. My inclination is potentially just to jump to Q&A because we have about 13 minutes. Jamie, what do you think?
Joel, let's do at least 2 cases.
Okay.
These are great cases.
Cool. All right. So a little bit more detail about case 1. This is a 20-year-old male post-valve replacement. He already got endocarditis once because of IV drug use. So was readmitted for complications of a second round of endocarditis with vegetations on his valve replacement. He had only partially completed a course of IV antibiotics, and he needed to be, the IV antibiotic treatment needed to be completed before his new valve. He is getting ongoing chemical dependency treatment and pain management, but part of the reasons he wants to leave AMA is because it's not just that he feels trapped, he also feels like his chemical dependency and pain management is not adequate. In the research, this is the top reason for patients leaving AMA, is they think that their pain management is inadequate. He's still housing insecure, and his decision-making capacity is unclear. What do you guys think now that we've gone through what I think are some of the relevant ethical considerations for AMA discharges? Pretty close to 50-50. Really interesting. 49% of you think that we should discharge the patient. 51% of you think that we should hold the patient. I think that's fair because I think a lot of the devil is in the details here. So procedurally, I think the best course of action is actually to work with the patient to figure out why he thinks his chemical dependency treatment and his pain management is inadequate. And to the extent that we could resolve his pain management and chemical dependency treatment issues, perhaps we can incentivize him to stay as opposed to leaving AMA. I do think that this is a case where an involuntarily hold might be justifiable because it actually is a very, very severe risk for harm. In this case, I think he still had a port, and that he would have potentially been able to go back out on the street and use this to do drugs, right? And this is on the background of an unresolved endocarditis. So this could result in death. On the other hand, the clarity about his decision-making capacity is really central. So to the extent that his decision is really an expression of his addiction, as opposed to a coherent and reasoned expression of his overall goals and values, in which case, if it was really a reasoned expression of his goals and values, then I think we would have an obligation to allow him to be discharged, right? In this case, the best case scenario and how it worked out is we worked with the patient to meet more of his needs for chemical dependency and pain management, right? So, yeah, these are really, really interesting and I think challenging cases, right? Because it could potentially go either way depending on the details. Should we do the next one?
Let's go to Q&A because there are some really great questions I want to get to. Maybe we can hop to the conclusion slide and I'll ask you, I think one of the questions that is popping up a lot in our Q&A is about surrogate decision making and the role that surrogates play. So I have two questions we can find in the Q&A that are about this. And the first one I want to ask about comes from Leslie Cuno. Hi, Leslie. That says, within the medical capacity hold, wouldn't you have an intermediate step of working with whomever is representing the patient without capacity and not allowing a dismissal requested by the patient when there's also, agreement of the representative or surrogate? Wouldn't that be enough to continue hospitalization? So do we really need this medical incapacity hold if we already have a structure that involves when people lack capacity, we look to surrogate decision-making?
Yes. So to the extent that there is an effective surrogate decision maker that can appropriately exercise substituted judgment and otherwise meaningfully participate in surrogate decision making, I think that you would have an obligation to honor what the patient would have wanted as represented by an effective surrogate. And that also includes an AMA discharge. So by analogy, let's take, for example, an end-of-life case where you have a patient, again, let's take the lung cancer guy, end of life, wants to die at home, has told his family he wants to die at home, but has lost decision-making capacity. I would say that his spouse or his adult children, who can reliably represent what the patient would have wanted, can ask for the patient to leave AMA because it's the most consistent with his interests and narratively what I think would be the most coherent for that patient. So it's important to say, when you have an instrument, if you have an advance directive, if you have a surrogate decision maker, and they're effectively able to represent what the patient would have wanted, I think that's something that should be respected.
So the medical incapacity hold really is helpful for patients who either we have to make, don't have access to a surrogate, or their surrogates are unavailable and they're asking you to make an immediate decision, something like that. Those are kind of the third step that we can use: patients, surrogates, then this incapacity hold, which is a potential, right? This is a proposed thing. It only exists at UCLA right now and maybe some other systems. And what you're recommending is that this would be a great thing to advocate for if we're thinking really seriously about this concept of AMA discharge.
I mean, I think it's really important, again, just to go back to the surrogate decision maker thing. It's important because then the burden now is actually about the evaluation of the appropriateness of the surrogate, which is a whole nother talk, right? Because you really, really want to make sure that you have an appropriate and effective surrogate that themselves possesses decision-making capacity, does know the patient's goals and values, doesn't have conflicts of interest or other impairments that would conflict with their effectiveness as a surrogate decision maker. But that's a whole other thing that you have to really be able to effectively do, is assess the appropriateness of a surrogate, especially if there are competing surrogates, right? But that's a whole different talk.
Can you speak briefly, and this is one of the questions from John in our chat, about the role that the family or surrogate plays in this decision to leave AMA? So, for example, if a surrogate is requesting that a patient leaves AMA, how should we generally approach something like this?
I would say that you should approach it the same as you would with any other sort of informed consent, or in this case, informed revocation of consent to treatment that you would in any other circumstance, right? And so you need to make sure that there aren't other constraints or kinds of coercion on the decision, that they have all the information necessary. And then, what I would propose is that you would also want to tell the surrogate, in the same way that you would tell the patient, that they have options for harm reduction, other support, even if they leave AMA, and that there isn't going to be other negative consequences or retaliation that would exclude them from follow-ups or returning.
That's fantastic. Thank you so much, Joel. We have a couple more minutes, so I'm going to ask some more questions. Let's talk a little bit about harm reduction some more. So this comes from an anonymous question. What if the dying patient is not able to take care of themselves and they request to leave AMA? So, they would not be able to get out of their bed and they don't have another person at home. What are our obligations in this sort of situation?
That's really hard. It's interesting because there's a paper where they talk about this specific issue, and the idea that, is it complicit if you take them out of the bed and put them in a wheelchair, or is it helping the patient if you take them out of a bed and put them in a wheelchair? Do you need to put them in a transport? Do you need to take them all the way home? And the argument in this paper that I agree with is essentially that, in the same way that locking a door on an ambulatory patient would be coercive and constraining and inappropriately, that, for example, a patient that can't walk, if you don't assist them in leaving, would be the same kind of coercion and restraint. So I think that's within a duty of care, and I think that's within a kind of ethically appropriate support. I think it's case specific. I will say, for example, with the case of the man with end-stage lung cancer who wanted to leave, we helped him get in his wheelchair. We helped with providing him with oxygen, and we also helped in securing a private medical transport. And we went so far as to get him in the van, and then once the van took off to send him back home, that was the extent of our support. I wouldn't necessarily say that it would go so far as to following a patient home or providing other cares, but I do think, to the extent that it's within the sphere of our influence and it's on hospital ground, there is an obligation. I hope that makes sense. Does that answer the question?
It does. And it made me think a little bit about like this harm reduction in combined with disability justice, or affirming, thinking about these patients who maybe lack ambulation, who don't have access to these sorts of things, is what obligations do we have to affirm their autonomy? And when it comes to mobility, we might have an obligation to provide mobility assistance in order to affirm their autonomy, right? That's something that's really reasonable for us to do if they have capacity, and even if it disagrees with how the clinical team thinks might be in the best medical option, right?
Right.
Okay. So another question we have, so when it comes to involuntary holds, one thing that comes up a lot is restraining patients. So can you talk a little bit about, in terms of like, how acceptable is it to engage in these kinds of physical limitations under the psychiatric hold, and then thinking about it from a medical incapacity hold as well?
So, I mean, this is a really hard question because I think it's case specific. From the ethics standpoint, it may not be a very satisfying answer. But from the ethics standpoint, what I would say is that you have to use the least restrictive means that are still effective in protecting the interests of the patient and preventing injury or harm, and also for the shortest duration necessary. So underlying that means that you have to reassess their capacity, so you're not burdening their autonomy for longer than necessary. And then you also have to really scale the levels of coercion and restraint to the specific situation. And that can be anywhere from bargaining, which is like relatively soft, and say, okay, we'll let you go outside to smoke if you do this, right? That's different than sedation or physical restraints. So those need to be reserved, and you should scale it to the least restrictive necessary to achieve a goal. Also, I think procedurally, it's important to the extent a patient does have the ability or capacity to participate, or some decision-making capacity, to explain to them the kinds of escalation that will occur. So it's not that you just drop the different kinds of coercion or restraint out of a vacuum. You explain to them that these are the incremental increases in the kinds of restraint that may be necessary to keep them safe, and that we'd like to use the least, that if they're amenable to participating. But if we can't keep them safe with those lower levels of restraint or influence, then we may have to escalate, right? So, I mean, it really is case specific and procedural to some extent.
Thank you so much, Joel, for your expertise, sharing your expertise on the issue of discharge against medical advice. We really appreciate all of your thoughtfulness in this presentation. And thank you all who have participated. You have, and the questions in the session were absolutely fantastic, and we could not get to all of them, but we really appreciate your participation. We have more events in the Center for Bioethics coming up. We have an Ethics Grand Rounds session that is coming up in September. So please check out our website for more information on events. And our next Unpacking Bedside Bioethics session is on conscientious objection, and that will be in November. If you are a UMN student seeking IPE credit, please follow the directions on the screen for information about how to attend our post-session chat. I will be there soon, and we're going to have a great conversation. Thank you all so much for attending, and we'll see you in the next session.